Okay, we're covering fluid, electrolyte, and acid-base balance. Okay, so we have different fluid compartments, and it's easiest probably to just approach this as the majority of fluid is found intracellularly. Thus is found inside all the trillions of body cells in your body, and that accounts for about 2/3 of the total body water. After that, everything else is considered extracellular. So some examples of extracellular fluid is any place else you might find water, and then you kind of have to be creative in your head. And remember, in blood we have 55% plasma, and 92% of that is water. We have interstitial fluids, that fluid that's kind of goes due to hydrostatic pressure, is pushed out of the arterial capillary side of circulation, and that some of that fluid is drawn back in, right, and becomes kind of a composition, a component of venous blood heading back to the right side of the heart. But that you also have certain amount of that fluid that's just interstitial. The lymphatic system should pick up the majority of that, and again, like, keep everything moving. But for a period of time, that fluid is sort of in that extracellular, interstitial kind of a location, before it's actually taken up into the lymphatic system. Remember that we have serous fluids. We have fluid that's part of the cerebrospinal fluid, GI secretions, saliva, tears, in joint capsules, between diarthrotic joints, that have lots of movement. So there are many other locations other than within cells. Okay, water is the main component of body fluid composition. About 60% is of males, is water, and 55% in females. When you look at the solutes and things that are found there, of course, there could be a variety of all kinds of things depending on what kind of metabolism is occurring in that particular area or in that particular organ. But most of it will be electrolytes, compounds dissociate into water or ions, and they're able to conduct electrical currents. So things like the sodium, potassium, hydrogenized bicarbonate ions, phosphates, sulfates, all these different salts, acids, bases, and even some of the proteins. Then we have non-electrolytes. These are substances are enabled to ionize due to covalent bond structures. So think of all those organic molecules and families that we looked at in chemistry and in digestion. Oops, there we go. All right, so comparison of solutes in ECF versus ICF. So the fluid differences reflect primarily the activities of the sodium-potassium pump. Remember, 3 sodium out, 2 potassium in cells, right? So in the cells. So remember, potassium's high concentration inside the cell, sodium and chloride is higher concentration outside the cell. This is a pretty cool chart to kind of keep in mind. When it comes to nursing and things, they're going to be talking to you a lot about fluids, fluid locations, and whether it's appropriate. What's called compartmentalization of fluids is the right amount in interstitial fluids, or as a component of interstitial fluid. Is it a normal component of plasma? What is the fluid volume in cells? Is it a normal level? Are those cells crenating and shrinking, or are they expanding? And that will introduce how different IV therapies will be addressed. So when you need to start by knowing which ions are in highest concentration inside the cell versus outside the cell. And they pretty much are just opposites to one another. So this chart is kind of handy because you have blood plasma and interstitial fluid. Blood plasma is the red bar, interstitial fluid is the blue bar, which essentially they go together in opposition to intracellular fluid, which is the gold bar. So on the bottom here, we have sodium, potassium, calcium, and look how they work in opposition to each other. If they're high in blood plasma and interstitial fluid, they're low in intracellular fluid, and then potassium, low in the red and the blue and high in the gold, which is intracellular. Calcium, not so much, they're mostly in and found in blood plasma and interstitial fluid, even small amounts. And then we have magnesium, bicarbonate ions, chloride. Look at the chloride, because the chloride will go with sodium, because where sodium goes, chloride goes, where salt goes, water goes. Look at the phosphate ions, very high inside the cell versus outside the cell. And the same with sulfate and proteins. So those are good to keep in mind. Fluid movement. Exchange is regulated by osmotic pressures. Remember, that's why we look so much at the different tonicities that maybe a red blood cell could sit in, or a body cell, and what effect would it have on that red blood cell. And we said, if because water, even though you have the fatty acid tails of the phospholipid bilayer that forms the cell's membrane, is that water can kind of squeaky through there often because of the osmolality, or the osmotic pressure between the inside of the cell and the outside of the cell. And that's why knowing what the osmolality of the solution a cell is sitting is very important. If it's a hypertonic solution the cell sits in, then it's going to draw fluid out of the interior of the cell and cause the cell to shrink. If it's an isotonic solution, it means that that ratio of solute to solvent is the same really inside the cell versus outside the cell. So it has no real net effect, a difference, in the size of the cell. Then you have a hypotonic solution that a cell could be sitting in. And this would cause water to flow into the cell and cause it to lyse, to expand, and possibly even lyse. So again, in the red, I think it was in the blood chapter, we talked about that again, looked at some pictures of the effect of different tonicities on red blood cells. If not, you might want to review the chemistry or the cell chapter. The cell chapter, I think chapter 3 from AMP1. Okay, so water balance. Normally, fluid gain balances fluid loss. Thirst is triggered by a decrease in plasma volume or an increase in solutes, which then can increase the plasma osmolality. So essentially, think of it, because I know in the nursing program, they love the term osmolality. Okay, so what does that mean? It means, that it's the concentration of solute to solvent. Essentially, what determines, whether you have a hypertonic solution that a cell is sitting in, or hypotonic. And so what's that ratio of solute to solvent? Right. Antidiuretic is the major hormone that regulates water loss. So remember, the antidiuretic is produced in the hypothalamus and stored in the posterior pituitary gland. And when you have changes in either osmolality or blood volume, and therefore blood pressure is dropping, you're going to secrete a lot of antidiuretic hormone, and it's very effective for opening up those aquaporins in some of the cells within the nephron, and allows water to go from inside the nephron back into blood circulation. But remember, there are other hormones associated with that too, like aldosterone. It just works a little in a more complicated manner. Let me just come back here and say that normally it says fluid gain balances fluid loss. And what they mean by that is if you are of a normal hydration level, and we're talking to talk about where you can lose some fluid here and there. We gain some fluid from the foods and the things that we eat and metabolic reactions, but we lose fluid in, perspiration, respiration, in tears, we're going to identify through urination, so forth, to certain amount of fluid that, lubricates the feces and so forth. But generally, if you have a stable hydration level and you're normally hydrated, is that if you drink a gallon of water, you're going to release a gallon of water in urine. not exactly, you're going to keep some of that, but pretty much what, first in, first out method, like in accounting, what you take in is going to be what you excrete, or liberate. However, because the kidneys are designed that, if you are kind of what's called hypervolemic, you take in more water. So you don't want to be secreting antidiuretic and aldosterone. You want that fluid that's now captured within the cardiovascular system as the blood passes through the kidneys to let that fluid overflow and not to reabsorb it. That's normal. All right, so here we have major sources of intake versus output of fluids. Intake to the left-hand side is through metabolism, about 10%, a lot from foods and a lot from beverages and things that we drink. Whereas the output, mostly in urine, we lose, we have what's called insensible loss via the skin and lungs, sweat, and feces. Right, water balance disorders. So dehydration, water loss from extracellular fluid exceeds water intake. Water leaves the intracellular fluid or the cell to maintain osmolarity. Thus, cells may cremate. What are some conditions that might cause severe dehydration? All right, so water loss from extracellular fluid exceeds water intake. So, when you're working outside or you've been at the beach for a long time, or you're mowing the yard and you're sweating and you're not taking in fluids as readily as you should, it means that the blood composition, instead of 55% plasma and 45% formed elements, you might be just the opposite, 45%. That would be pretty extreme. Let's say 50% plasma and 50% formed elements. That makes, the blood increases its osmolarity. And thus, it acts like a hypertonic solution on those cells, and it causes them to maybe cremate. Hypotonic hydration is another type of disorder. Overhydration, too high and rapid intake of fluids results in a hydration in all compartments. All right, so the cells, you first start by increasing the volume in plasma, which then overflows to interstitial regions, to the lymphatic system. Essentially, the water goes all over at some point. It's lost at the capillary level. It's still in the interstitial spaces. It's being picked up by the lymphatic system. It's doing the best it can to return it back to the blood. As the blood circulates to the kidneys, we hopefully then produce more urine and decrease the pressure within the system. So if we have a hypotonic hydration issue, like hyperhydration, that's what I'll just refer to it as, then what effect does it have on the cells? Well, now it had the opposite. Now the cells have a tendency to expand. Fluid will move into the cell and cause it to get larger and maybe even rupture. That can be treated with just a plain hypertonic saline solution, an IV administration. That will cause the fluid to be pulled back into the bloodstream. And again, let it just pass through the kidneys over and over again. Let the person continue to form urine and expel all the extra fluid. Edema is when fluid accumulates in interstitial spaces, and it can occur for many, many, many reasons. Increasing capillary hydrostatic pressure, or maybe incompetent valves, such in not only veins, but in congestive heart failure. The interstitial fluid osmotic pressure from inflammation processes can cause this. Decreased capillary colloid or osmotic pressure, which means that all those, remember we talked about albumin, maintaining an osmotic gradient in blood. The fact that the red blood cells and white blood cells and all these proteins should stay in blood. That's why they shouldn't, and especially the larger proteins, should never be part of filtrate in the kidneys. It should stay in the blood because you want those molecules and those cells to stay there. And it keeps drawing fluid back into the cardiovascular system where, again, if you have a fluid overload of some kind, then eventually it travels to the kidneys and you're able to urinate and eliminate it. But if you don't have the proteins there, if you have liver damage and liver disease and you're not making proteins, because remember, those proteins are made by the liver. If we have vessel injury, that will do it. higher blood pressure, which, again, increases the hydrostatic pressure, the push out, at a capillary level, malnutrition and burns. Okay, sodium and water balance. Regulation of water output in urine is closely tied to sodium. Remember, where water goes, salt goes. So loss of water will then parlay into a decrease in blood volume and therefore blood pressure. So remember, if we want to increase blood volume and blood pressure, we're going to use antidiuretic first, but then you can use aldosterone to actively pump sodium. Chloride follows, water goes with it, and we secrete potassium. If we don't want, if we have too high blood pressure, we're going to inhibit, further secretion of antidiuretic and aldosterone. Sodium balance, so the primary regulator of extracellular fluid volume and water distribution is going to be sodium. Because where sodium goes, chloride goes. Where salt goes, water goes. And it's the most abundant cation in extracellular fluid. Sodium is reabsorbed by the PCT and the nephron loop, the loop of Henle, to maintain normal levels. Remember that the regulation of sodium is controlled not by an antidiuretic, because antidiuretic only absorbs water, but with aldosterone, renin-angiotensin, and ANP. Remember, the ones in red are used to increase blood volume and blood pressure, and 3 in blue, in the atrial natriuretic peptide, is when you have high blood volume, high blood pressure. So you can read through this again. This is about the 4th time we've covered this, that a decrease in sodium or increase in potassium levels in extracellular fluid may stimulate aldosterone to be released. Remember, sodium will be reabsorbed, chloride follows, water follows it. We secrete potassium. That can be due to either low blood volume, low blood pressure, or maybe increased potassium levels. And now we're trying to get rid of potassium. The renin-angiotensin loop stimulates the thirst area of the brain, as well as further secretion of antidiuretic and aldosterone. And so here's how those work. Again, this is from the endocrine system as well, this image. If we have an increase in blood volume and blood pressure, which was that one in blue, then we secrete atrial natriuretic peptide. Remember, that comes from the atria of the heart. It inhibits further secretion of antidiuretic and aldosterone. It also inhibits renin secretion and helps to lower, therefore, lowers blood volume and blood pressure. Once you stop secreting hormones that are actively trying to absorb fluids and you block them, then again, as the blood passes to the kidneys, that fluid is going to be eliminated. As long as, I would say you have normal functioning, of the kidneys. But sometimes the system just doesn't turn off well, so you have to actually have something like AMP, to decrease any or inhibit any further ADH, aldosterone, or renin secretion. All right, so this is the mechanism and the consequences of AMP. So you can, again, look through that. We looked at that in the endocrine system. I believe it was that, and the blood vessels. Chloride is the most abundant anion, negative charged ion in extracellular fluid. Where sodium goes, chloride goes, all right? But don't forget that you'd also have the chloride exchange between bicarbonate ions in the red blood cells, called that chloride shift. That if bicarbonate ions are in high concentration inside the red blood cell, because we're actively converting carbonic acid down to hydrogen ions, bicarbonate ions, that those bicarbonate ions will actually flow from inside the cell to outside the cell and diffuse. And when that happens, a chloride ion from outside the cell will swap places essentially with the bicarbonate and enter the cell. And then vice versa. If bicarbonate ions are really low within the red blood cell, then bicarbonate ions outside the cell will flow into the red blood cell, and a chloride ion from inside the cell will go out to the extracellular fluid. So that's that chloride shift. It's just part of that. Remember that. Right, potassium is needed to maintain more resting membrane potentials, as you know. Aldosterone increases secretion of potassium into the collecting ducts. Aldosterone promotes potassium secretion by reabsorbing sodium in the collecting ducts. So that mechanism, both of those things are going to have to happen. But if you need to eliminate potassium because you called what's called hyperkalemic, you need to remove potassium because those potassium levels are very irritative, so to speak, to cardiac muscle contraction. Remember, normal levels of potassium are only about 3.5 to 5.0 milligrams per deciliter, and even small deviations from normal, can produce cardiac arrhythmia. Okay, the regulation of potassium balance, the importance of potassium is it affects that resting membrane potential in neurons and muscle cells, especially cardiac muscle. So increases in ECF. Potassium is called hyperkalemia. So picture potassium in the kalemia in K. So you keep that together. Causes a decrease in resting membrane potential, causing it to depolarize. So when we say a decrease RMP, we mean it's getting closer to zero, closer to threshold. When we have a decrease in potassium levels, extracellular, that's called being hypokalemia, meaning a low level in the blood of potassium, and causes hyperpolarization and thus non-responsiveness. So when it's low in outside the, in blood, then it causes the interior of the cell to hyperpolarize. Think about, if it's low, if it's extraordinarily low in blood and it's supposed to be high in the cell, then, more of that potassium through those leakage gates is probably going to escape. And that makes the interior of the cell more negative, not more positive, more negative because you're losing some of these potassiums. So it hyperpolarizes you. Disruption of potassium, either hyper or hypokalemia in the heart, can interfere with electrical conduction, leading to sudden death. So those levels are really, really important to be maintained. Bicarbonate is the major buffer in extracellular fluid. Concentration is greatest in the veins, where we have a higher, in veins is where you have higher levels of carbon dioxide, because that is what you've now kind of captured at the, at the capillary level, and is now transporting, so it can be, transported to the lungs where you can exhale essentially. But that, we start buffering that very quickly, interacting. Remember, the water, the carbon dioxide will interact with water in the carbonic acid cycle and start producing more hydrogen ions and bicarbonate ions. So its concentration is highest in the veins. Kidneys are the main regulators to reabsorb and secrete based on the blood pH. And we know that too. We looked at, what might be secreted and reabsorbed if you had certain pH levels, as the filtrate is passing through the distal convoluted tubule and the collecting ducts. Calcium regulation needed for most bones, but also for clotting and neuromuscular excitability as well. Remember, we had that calcium plateau, in cardiac muscle contraction, mainly regulated by parathyroid and calcitonin, the parathyroid hormone, and ultimately calcitriol, that is formed by the conversion of vitamin D to calcitriol in the kidneys, increases blood levels of calcium from bone in the small intestines and the PCT in the kidneys. So when we have low calcium levels, we use parathyroid hormone. It targets the kidneys to reabsorb calcium. It also converts vitamin D to calcitriol. That targets the small intestine to reabsorb calcium. And then it also stimulates osteoclasts to break down bone. And thus, all those sources increase blood calcium levels. Calcitonin is released when we have higher than normal blood calcium levels. It will inhibit the osteoclasts, meaning stimulate the osteoblasts, so that now we have some extra calcium. Let's store it in bone for later, and then let the rest of it just be eliminated through urine. Okay, acid-base balance and its importance. So protein shape, remember, is very sensitive to hydrogen ion concentration, and thus, the pH level. Proteins are denatured in acidic environments, as well as very basic environments, but we have more opportunity for acidic environments in the body. And protein shape is also influenced by temperature as well. But we're, because body temperature is another thing primarily controlled by the hypothalamus and the autonomic nervous system, we're going to address how these other systems can help maintain appropriate 7.35 to 7.45 pH levels of blood. The pH of veins and interstitial fluid are more acidic, than arteries because of the high CO2 levels. And most hydrogen ions are released as end products of cell metabolism. When we break down those proteins, carbohydrates, fats, nucleic acid, all our four organic families, we looked at the building blocks of all of those. But those building blocks can get broken down and do. And when they do, they all get broken down into some kind of an acid. And therefore, those acids, upon metabolizing those building blocks, will be an ultimate source of hydrogen ions. Right, so hydrogen ion concentration regulation is controlled by three ways: through the chemical buffer systems, through the respiratory system, and the renal mechanisms. The chemical system is the first. That is the available buffers that are found within plasma itself, that are kind of free floating there. But we also know that we can control the respiratory rate to increase or decrease carbon dioxide being released or not. So if we want to release more carbon dioxide, we increase respiratory rates. If we want carbon dioxide to kind of build up and let hydrogen ions to build up, then we can decrease respiratory rates. Well, that goes back to our review, some of the labs and some of the material we covered in the respiratory system, as well as the renal mechanisms as well, that I just mentioned, to reabsorb or secrete hydrogen and bicarbonate ions as needed at the distal convoluted tubules of the collecting ducts to adjust the pH. Remember also is that in the PCT, we freely release hydrogen ions, and we reabsorb about 85% of the bicarbonate ions in the primary convoluted tubule also. And that's really happens almost regardless of the current pH value, but especially at the end, where now some of the blood that we did not get a chance to really buffer before, we now have an opportunity to last ditch effort, is as the blood is passing through there, is modify the pH of that blood that's passing through the peritubular capillaries and the vasa recta. Okay, so of the chemical buffers, we have what's called the BPP, the bicarbonate buffer system, the protein buffer system, and the phosphate buffer systems. Technically, those are our three chemical buffers. The bicarbonate / carbonic acid buffer system is the only extracellular buffer. The protein buffer systems and the phosphate buffer systems are found intracellularly, and of those two, the protein is the most abundant in intracellular fluid. All right, I'll give you that. So that if it starts, you can look at albumin, but the albumin and the proteins within a cell instead of outside the cell. But primarily what we're going to be looking at is the bicarbonate carbonic acid buffer system, looking at the carbonic acid cycle. But there are protein and phosphate buffer systems that are found intracellularly. Okay, so as a review, the respiratory system also is going to act to adjust blood pH. These chemical buffers, they happen immediately. But we can exhaust all those buffers that are available, and now you still have either too high or too low blood pH. So we are directly able to change the pH by changing our respiratory rates and therefore carbon dioxide levels in blood. But remember, there's normal levels of carbon dioxide. It's 35 to 45 millimeters of mercury, right? There are normals. We just, don't want it to, if it goes too high or too low, above or below that, then we need to make some modifications. When we have conditions of hypoventilation, hypoventilation increases the carbon dioxide levels and therefore increases hydrogen ions and decreases the pH and causes acidity. Or let's put it this way, it decreases the pH. It may not cause it to become an acid, we might try and purposely hypoventilate if our blood pH is too high. But we're going to look at some of these, as we progress, through the remainder of the notes. So when you have hypoventilation, or when you are hypoventilating, you don't liberate and exhale as much carbon dioxide. CO2 increases, produces more carbonic acid, produces hydrogen ions, decreases pH. Chemoreceptors in the medulla and the aortic and carotid bodies, remember, in the medulla oblongata, in the aortic and carotid bodies, monitor. Remember, we have those peripheral and intrinsic internal chemoreceptor areas, and together they give you brain feedback about the pH of your blood. And as pH levels decrease, the respiratory center in the medulla will be stimulated to increase ventilation. So you could be hypoventilating, causes the pH value to go down ultimately, and that tells the brain, hey, we need to start increasing the respiratory rate again. Don't keep hypoventilating, or if you're holding your breath, stop and start ventilating again, so we can decrease our carbon dioxide. Hyperventilation does the opposite. Hyperventilation reduces the carbon dioxide levels. Now you're getting rid of too much. And yes, you might have oxygen levels that are, adequate and higher than normal, or, fully saturating virtually, but you need to have a certain amount of carbon dioxide. It needs to be in a normal range. So now you're reducing it too low. Now you have lower than normal carbon dioxide levels, hydrogen ions, concentration decreases, pH value increases, and produces alkalosis. That continues. And again, the same chemoreceptors that we looked at for hypoventilation in the medulla oblongata, the aortic and carotid bodies, they will then stimulate a decrease in the respiratory rate and allow the carbon dioxide level to increase, and therefore increase hydrogen ions and maybe decrease the pH to a normal range. So respiratory secretion of carbon dioxide just talks about the sequence. Cells increase production of carbon dioxide, and they do that through just cellular respiration, as we've looked at that, is the different steps of glycolysis, formation of acetyl-CoA, citric acid cycle, the Krebs cycle, and so forth. Well, not the citric acid cycle, but the Krebs cycle, as sources of carbon dioxide. And because we're constantly, these cells are using oxygen and substrates to make ATP, because they all have these different pumps and things that they actively do, then we have a constant source of carbon dioxide. Carbon dioxide reacts with water to produce carbonic acid, and carbonic acid releases hydrogen ions. Respiratory center is stimulated, rate and depth of breathing increases. We decrease our carbon dioxide levels, from the blood as it passes through the lungs. And then we start to, again, looking at the carbonic acid cycle, is to then modify the blood pH. Renal mechanisms, remember the PCT and collecting ducts, and in the distal convoluted tubules, we secrete excess hydrogen ions and reabsorb bicarbonate as needed. We reabsorb a lot of bicarbonate right at the beginning of the PCT, and we'll secrete hydrogen ions, at the proximal convoluted tubule. And then if we overdo, underdo, we're going to modify it at the end. Right, so renal secretion of hydrogen ions. Nephrons help regulate the hydrogen ion concentration of body fluids by secreting hydrogen ions in urine, as you know. So this just gives you an example of, let's say you have a high intake of proteins, and we're breaking down, those proteins to amino acids, and the amino acids we can break down as well. Causes an increase in sulfuric acid and phosphoric acid. Again, that leads to an increased concentration of hydrogen ions, because all these acids, whether they're a weak acid or strong acid, are going to break apart to a certain extent and release those hydrogen ions. And therefore, this is the source of a changing hydrogen ion concentration. Increased secretion relates into increased secretion of hydrogen ions in the fluid of the renal tubules. So now the blood is passing to the kidneys. We're going to allow the hydrogen ions to be liberated, and essentially secreted into urine. And therefore, the concentration of hydrogen ions in the body fluids returns toward a normal level. So time course of blood pH. Well, various regulators of hydrogen ion concentration operate at different rates. The chemical buffers, the first one we looked at that, functions the most rapidly. But then when we kind of exhaust the availability of those, then we start using the respiratory and the renal mechanisms. So we start adjusting the respiratory rate and allow the kidneys to do their thing. The respiratory system is the most sensitive, and you can make very quick out of the two of those. The respiratory system, as long as it's again functioning correctly, we don't have a lot of pathology there, then the respiratory system will make the most rapid adjustments of respiratory rate to adjust the current pH. But the kidneys will do so as well, as long as they, again, are functioning normally. But you can only buffer so much the blood that's currently passing to the kidneys, and the blood, significant amounts of blood, travel very rapidly through the lungs and very quickly. So the two of them together will kick in, but generally the respiratory side is going to be the most sensitive as long as it's capable of doing so. All right, so normal values for an arterial blood gas, and this you need to commit to memory. pH, as you know, is 7.35 to 7.45. The normal levels of bicarbonate in blood are 22 to 26 milliequivalents per liter, and carbon dioxide is 35 to 45 millimeters of mercury. So I'm not going to ask you, about the units of measurement. I'm not going to give you questions that will mess with that and say, instead of being milliequivalents, is it milligrams per liter or something? I just want you to know what those units of measurement are, like for gases, like arterial, like when we take a blood pressure, we use millimeters of mercury. Carbon dioxide is measured the same way. Right? So, but do you know the value, the range is 7.35 to 7.45, 22 to 26, and 35 to 45. These are the normal values from arterial blood counts, not venous, but arterial sample. Okay, so when it comes to acid-base imbalances, chemical and physiological buffer systems ordinarily maintained a hydrogen ion concentration of body fluids within these very narrow pH ranges, but abnormal conditions may disturb this acid-base balance. So love this scale. So on the bottom here, we have our pH scale. We have 6.8 to 8.0. You can see on the bottom, that's your survival range. The normal pH range is 7.35 to 7.45, narrow. So even though we're not below 7.0, anything less than 7.35 toward, 0 is considered acidosis. And anything in excess of 7.45 is considered alkalosis. So really important, speaks volumes, image. All right, survival range is 6.8 to 8.0. Normal range is 7.35 to 7.45. Any pH value obtained that is less than 7.5, it will be some kind of metabolic or respiratory acidosis, just based on the pH level. And if it's higher than 7.45, we call it alkalosis. Right, and that's essentially what this is describing. Normal pH range, if it's above 7.45, we call it alkalosis. Below 7.35, acidosis. All right, so when we have acidosis, it can be from two different general sources of etiology, so to speak. The respiratory acidosis sources are pretty straightforward because it has something to do with the respiratory system. Maybe those factors associated with airflow. When we talked about the respiratory system, we talked about factors that influence airflow into and out of the body. That affect diffusion at the respiratory membrane, huge. The dissociation of oxygen from hemoglobin on those curves. Those different factors, come in now, because once you understand, what a certain pathology or something that a patient is experiencing, if it affects, let's say, the airflow, the diameter maybe of the trachea or the bronchi, or the bronchioles, where you can bronchoconstrict and dilate, where you can regulate how much airflow is into and out of the lungs. Then you can start to see, okay, would carbon dioxide build up in the blood, or will it cause you to lose more carbon dioxide. Well, I think the respiratory side is much easier to see. When it comes to metabolic acidosis, which are metabolic sources, it's a little more complicated. So respiratory is pretty much about the respiratory system with a couple exceptions, like head injury and all-out cardiac failure. All right, so they're here to the left-hand side says accumulation of carbon dioxide. So there are three major sources of that. You can have a decreased rate and depth of breathing, like you're holding your breath maybe, head injury or heart failure. So head injury, what they're talking about is that you might have significant head trauma that causes maybe a subdural hematoma. And when that develops, especially around the parietal lobes and the maybe frontal lobe or occipital lobe, kind of where the lambdoidal suture is that if it's significant enough, kind of from the top, pushing the brain downward, the medulla oblongata becomes compressed around the foramen magnum because it's kind of being shoved down into the vertebral foramen, or where you should only have spinal cord and not brain. And once you compress that medulla oblongata, you can see a cessation to breathing. All out heart failure will, of course, increase, cause nothing to circulate, and so that will cause an increase of carbon dioxide as well. All right. Then we have in the middle obstruction of air passages, like choking, maybe extraordinary asthma, really bad asthma attack, or bronchitis. That will increase, either inflammation of fluid in the lumen of these passageways. And if you can't get air in, you can't get carbon dioxide out. And so, again, the carbon dioxide builds up in blood. Decreased exchange. This is at the respiratory membrane area. We talked about other factors such as surface area. We don't want to have all these alveoli, all these little grapes on a little grape stalk, with all their membranes of the squamous cells that form the walls of alveoli and their capillaries adjacent to them. You want lots of those because the more exchange opportunity you have, on all those walls, allows a lot of carbon dioxide to be diffused out of blood. And, the blood, takes less than a second for blood to pass through the lungs and have this exchange take place. So when you have something like emphysema, which you have a coalition of alveoli, then you're cutting down on the surface area for this gas exchange to occur. Or in the case of pneumonia, you have fluid, accumulation. If you have too high pulmonary pressure, where it's hard to pump the blood from the right ventricle into the lungs, and so very limited amount is traveling through there, and the pulmonary pressure can actually start compressing the blood vessels, just like blood vessels being compressed as they travel through the myocardium of the heart, and the heart is in contraction phases and in systole phases. That squeezes down on those blood vessels. So the majority of blood circulation through the myocardium of the heart is during its relaxation phases of every heartbeat. You want to then relax that muscle, and the blood, passes right through those vessels again. And it's the same in the lungs. You want to decrease that pulmonary pressure, or decrease the fluid and the thickness maybe between, within the respiratory membrane, between the capillary layer of your, or the endothelial layer of your capillary and the simple squamous of the alveoli. So all those resort into or produce an accumulation of carbon dioxide, and therefore carbon dioxide increases, hydrogen ion concentration increases, pH value decreases. And so that produces the acidosis, and the source of that is called being respiratory, because it comes from a respiratory, essentially, etiology. But if we have what's called metabolic acidosis, it's much broader. And so when it comes to metabolic issues, whether it's acidosis or alkalosis, you could either be having a change to the hydrogen ion concentration or the bicarbonate ion concentration, right? Because they're a balance. So let's look at on the top. We could either have an accumulation of hydrogen ions, which produces the acidosis, and that could be things like kidney failure, abnormal circumstances, and when there are abnormal changes here. So let's say we're incapable of secreting the hydrogen ions. Excess production of different acids, like We talked about ketoacidosis in diabetes mellitus patients that are burning more fats. We said that burning all those fatty acid tails produces the ketone acids, and that those, again, acid releases a lot of hydrogen ions. Could be due to over ingestion of certain things like salicylates, which is aspirin, and salicylic acid. So those are all, examples of, not restricted to, accumulation of non-respiratory acids. Right? That can all lead to metabolic acidosis. Or we could have an excessive loss of base, of bicarbonate. All right, so to become acidotic and a drop in pH, we could either have too many hydrogen ions, or we might not be, we have an excess loss or inability to absorb even bicarbonate for some reason. And now essentially you have the right number maybe of hydrogen ions, but we just don't have the available bicarbonate to buffer it like we normally would do. And now essentially, because we have nothing to buffer and offset those hydrogen ions, the pH value starts to decrease. So an example, a very good one that's going to come up in nursing things, will be prolonged diarrhea. When you have prolonged diarrhea, a lot of the bicarbonate, from the pancreas is normally in the small intestine. You generally have a lot of time to reabsorb a lot of that. And if you have diarrhea and it's past, what's called gut kind of hyperactivity, it's going to pass through rapidly through the small intestine, large intestine, and you don't have enough time to absorb that bicarbonate. You'll also lose fluids as well, and water, we know that, but the water doesn't directly affect the pH like losing all that bicarbonate will. All right, so we have acidosis, drop in pH to either increase hydrogen ions or decrease bicarbonates. All right, so alkalosis, effect on the body, increases excitability of the entire nervous system, leading to spasms, tetany, convulsions, and death. All right, this is just kind of keep in mind, especially if you're reading through, any kind of nursing websites. If they tell you that a patient is going through these things or experiencing these things, and they generally give you more than that, then you're at least at the alkalosis. Before we looked at acidosis, now we have higher than normal pH. All right, so we can again either have respiratory alkalosis or metabolic alkalosis, just like in the previous. We could either have acidosis, either from a respiratory etiology or a metabolic etiology. So if you have respiratory alkalosis, it's 9 times out of 10 due to some kind of hyperventilation issue. Why you're hyperventilating, you just have to kind of look at what's going on in the patient's history. But a lot of these, because of you're just hyperventilating. Things like or reasons, would be, not things like reasons would be down below here: a hypermetabolic condition, fever or anemia, gram-negative sepsis, hysteria. Cirrhosis of the liver can also stimulate hyperventilation, but we're not going to get into that too much. So let me go back to the top. It's a result of hyperventilation. How would hypermetabolic conditions such as fever or anemia come in? Because when you have fever, you're increasing body temperature. And for you to increase body temperature, you have to have muscle contraction. And to have muscle contraction, you need substrates like glucose and oxygen. And in doing so, and the muscles working like that, it also produces a lot of carbon dioxide. So you need to increase your respiratory rate to meet the metabolic kind of demands here of muscle that's trying to increase your body temperature. Anemia, depending on how severe it is, because, if we have anemia, we're not transporting enough oxygen, and your chemoreceptors keep picking up on that. And goes, well, we're not oxygenated enough. You need to breathe faster or breathe more frequently. So yes, it's delivering more oxygen in the case of fever so that we can continue with aerobic respiration. And we're transporting as much as we can, with what red blood cells, we have that are normal. But in doing so, we're blowing off more carbon dioxide than we want. And therefore, our CO2 levels are down, and hydrogen ions are down, and pH value goes up. Gram-negative sepsis is rather similar. It's associated with trying to increase body temperature. Hysteria, just being panicked about something or scared. Back to the top, hypoxemia caused by pulmonary disease, high altitudes, or congestive heart failure. So an inability to oxygenate blood. The red blood cells are fine. It's not like anemia. It's not like you don't have normal red blood cells, or you have some kind of abnormal hemoglobin. It could be due to pulmonary disease, like we just said before. Maybe one of your uh, maybe chronic bronchitis, some other kind of pulmonary disease like that, emphysema. All those will lead to a carbon dioxide buildup, either in blood to cause you acidotic, or it could cause alkalosis. It just depends on what the pulmonary disease is. High altitude, because you can't oxygenate your blood adequately. We're at higher altitude, so that the concentration gradient and the pressure gradients, that are normal closer to sea level, accentuate oxygen going from inside the alveoli into the blood, and carbon dioxide, where it's high concentration in the blood, into the alveoli. You have these enough pressure differences, and when you go to higher altitude, you lose that. So it's harder to oxygenate blood, and you start again hyperventilating a little bit, and or a lot even, and blowing off the carbon dioxide. Congestive heart failure is when generally right side, is when the heart does not pump blood, the right ventricle, into the lungs and keep it moving forward, in appropriate manner. The heart expands and that chamber expands, but it doesn't contract fully and eject the majority of the blood that's in that chamber. And so, we're not moving blood well to drop off the carbon dioxide and pick up oxygen. So congestive heart failure can cause alkalosis. Then we have metabolic alkalosis, generally result from a loss of hydrogen ions. A good example of that is prolonged vomiting, or a gain in hydroxide ions, such as ingestion of antacids and diuretics. Keep in mind, when they say prolonged vomiting, especially in the nursing questions, what they want you to picture is that you just keep kind of habitually. It doesn't have to be a lot violently, just within 24 hours. It means like over time, you keep vomiting, and a lot of the hydrochloric acid from your stomach, you're losing that in vomit. Essentially, you're not vomiting up so much that you're pulling bicarbonate from the duodenum, into the stomach, and now it's a loss of bicarbonate as well. They're just trying to distinguish, when you have prolonged vomiting, you're losing the hydrogen ions of the hydrochloric acid that are generally a normal part of ions being absorbed from the stomach. And when you have prolonged diarrhea, you're losing bicarbonate. So one is going to make you acidotic, one is going to make you alkalotic. Or it could be a gain of hydroxide ions, such as, ingesting too much substances that act as buffers, like antacids or even diuretics. Those can be sources of metabolic alkalosis. All right, then we have what's called compensation. So compensation is adjustment made when one side is the contributing factor to the acidosis or alkalosis. So what do we mean by that? We mean that if you have a respiratory acidosis, generally means that you have some problem in the respiratory system. And therefore, the area that will eventually compensate is going to be your kidneys. I mean, you're going to really be relying on your kidneys to make an adjustment, instead of both systems working together. Now it's pretty much just up to the kidneys, or what we call renal compensation. If we have a metabolic respiratory acidosis or alkalosis, then we generally see a respiratory compensation, as long as the pulmonary system is working normally. So the kidneys compensate when there's respiratory acidosis or alkalosis, or we call it renal compensation, or the respiratory system compensates when there's a metabolic acidosis or alkalosis. It's assuming that one side is normally working, is capable of doing the job. Now, truth be told, there are issues with that. I mean, if you do have someone that has multiple different pathologies going on, related or interrelated to one another, then yes, this person is going to have problems with this chronically. Okay, so acid-base imbalance categories. So once we've determined whether, and we will be able to determine whether we have a metabolic or respiratory acidosis or alkalosis, then we need to determine what phase it's in. In the early stages are what's being called uncompensated, because maybe the respiratory, the renal system has not kicked in yet. We're in the early stages. Eventually they will, but they haven't yet. So very early stages. Then we'll see partially compensated, which means that, okay, now we're starting to, maybe the renal system is starting to make adjustments to the pH, and so what will we see and how will that look in arterial blood gas? And then we can have fully compensated, which is not normal. It just means we fully compensated, which means your pH will be of a normal range. The other two bicarbonate hydrogen ions will still be out of normal range, but they're working on getting back, and that hopefully you come back to a normal pH range. Sorry about that. I've got a text coming in. Sorry about that. Okay, so as we're passing through this, and really for lecture class, I really want you to know what are some of the sources and the reasons, clinically they can make you acidotic or alkalotic. And we're going to look at some of those. And then all you will have to do for lecture class is to identify whether you're metabolic or respiratory acidosis or alkalosis, generally limited to an uncompensated level. But we will talk about how you would tell the difference between these different stages, because it's really helpful when you get into your advanced programs to understand how you're getting there. There are different ways to remember this that you'll be taught when you're in your program, these different ways of drawing, I think, a ladder or something that says, oh, if they go in the same direction, then it must be this. And if these two go in the opposite direction, it must be that. And in a way, yes, that is true. I think if you just really understand the carbonic acid cycle, then it makes more sense, and it's less, you really understand why this is happening, instead of just memorizing when something goes together, because usually that doesn't work out so well. But anyway, it helps to identify the different stages progressively from normal to uncompensated, partially compensated, and fully compensated states, and back to normal. You can quickly identify what stage the patient is in once you know the arterial blood gas values. Right. So this is what I kind of came up with that helps you kind of visualize this cycle that you would go through. So let's start at the bottom. We start with normal, where everything is normal, and arterial blood gas gives you other oxygenation levels as well, but it has no real bearing on the pH that you're looking at. Only pH, carbon dioxide, and bicarbonate levels are important. So we're going to start by looking at the arterial blood gas of a normal person. At some point, something starts to happen, which takes you to the blue at 9 o'clock, uncompensated respiratory or metabolic acidosis or alkalosis. Then it'll progress to a partially compensated respiratory and metabolic acidosis or alkalosis. And then finally, or I shouldn't say finally, the next stage would be a fully compensated, in gray, metabolic or respiratory acidosis or alkalosis, and then hopefully back to normal. That's the progression. Okay. All right. So, what I want you to picture is that if I have some kind of uncompensated, let's say it's a respiratory acidosis, is that it will always be called respiratory acidosis, but now it's going to go into a partial respiratory acidosis, or partially compensated. And then it'll be a fully compensated respiratory acidosis. And then hopefully back to normal. And hopefully the patient becomes normal again. However, when you get this arterial blood gas and you just get a printout of some current values, you should be able to determine, hey, am I in early stages? Am I starting to compensate? Hey, is it a normal pH range, but my carbon dioxide and bicarbonate levels are still off? That means, all right, that so far the body's doing what it needs to do. It's getting closer. The most important thing is your pH is normal. That has to be maintained. You can only survive 6.8 to 8.0 when you start doing damage to all those proteins. So, the goal is to have everything come back to normal, back to, that magenta, or purple kind of a square down there. But, the first and foremost is to get the pH back to a normal range. And then as long as you've hopefully corrected and made an adjustment to whatever caused the problem in the first place, then everything should come back to normal. Right? So when we're normal, your pH is in a normal range, your carbon dioxide and your bicarbonates, they're all within normal ranges, and thus you are normal. But something starts to change, and this is what's going to happen. Your pH will, of course, go out of range. You're either above 7.35 or 7.45, or you're below 7.35, right? You're out of your normal range. So that, as well as one of these, CO2 or bicarbonate, is going to be abnormal, and the other one's normal. And that's how you're going to determine if it's the carbon dioxide and it makes sense, then it's going to be called a respiratory acidosis or alkalosis, depending on what the pH is. And if the carbon dioxide is normal and the bicarbonate is out of range, then we're going to call it a metabolic acidosis or alkalosis, whatever the pH was. You start by looking at the pH. Right? Partially compensated state means the pH is abnormal, and the carbon dioxide and the bicarbonate, they're all abnormal. What you found previous, oopsie doodle, I just went right back to the beginning because I hit the wrong button. I'm sorry. Let me go back. We'll kind of get the knack of this. This is why I have the seminar on this, right, is that whatever you found here in the uncompensated state, let's say it's the respiratory acidosis, it would be high carbon dioxide and low pH. When it moves into a partially compensated state, you're still going to have a lower than normal pH and a high carbon dioxide, but now the bicarbonate will start to adjust to make sense. You'd have to increase your bicarbonate levels to help interact with the excess hydrogen ions of the pH, of the pH of the blood. I mean, it's acidotic because you have too many hydrogen ions. So if we have more bicarbonate available in blood and we start maybe reabsorbing that in the kidney tubules, then it will interact with those hydrogen ions. Hydrogen ion concentration decreases, the pH goes back up to a normal range. And we had tried to address the reason why maybe the carbon dioxide levels are higher, but those will kind of go hand in hand. It won't all of a sudden be switched around. It will start being corrected and maybe improving the pH. Then we get to a fully compensated state. And now we've been able to stabilize the pH to a normal range, but that carbon dioxide and bicarbonates may still be out of range. Maybe not as severely as they were before, but they're getting closer to normal ranges. And so pH is normal and the other two are out of range. And then hopefully we come back to normal. All right, that takes us to the carbonic acid cycle. Again, CO2 plus H2O yields carbonic acid, H2CO3, which yields bicarbonate ions and hydrogen ions. Right, so in respiratory acidosis, our normal range, the carbon dioxide is 35 to 45 millimeters of mercury. So, this is what determines whether you have respiratory acidosis. And these are the things that can cause it. Well, we know we're going to be acidotic. Look here on the bottom. These are the conditions that must be met to call it respiratory acidosis. So you have a pH that's less than 7.35. Right, so that we know anything below 7.35, we call it acidosis. And to be a respiratory acidosis, you must be also looking at carbon dioxide levels in excess of 45, higher than normal. Right. Why? Because when we go back to the carbonic acid cycle, increase CO2, increase your acid, increase your hydrogen ion, decrease your pH level. That's how you got acidotic. Right? So back kind of to the top here, any condition that causes CO2 to back up and accumulate in blood is going to be a respiratory acidosis. So, sometimes you can just be given the history of a patient And that should direct you into, okay, even though I don't have a particular level to look at, maybe the ABG, I'm anticipating carbon dioxide building up. So hypoventilation increases CO2 levels, maybe above 45 millimeters of mercury in the blood, and acid levels are increasing in the blood. This includes any pathology that inhibits the diffusion of CO2 from the blood to the alveoli, such as hypoventilation, emphysema, pulmonary edema, which pulmonary edema is going to also increase pulmonary pressure, obstruction, brain injury. You're choking on something. You get a blow to the head, subdural hematoma, medulla oblongata through the foramen magnum. This produces a drop in the pH, which is the reason why we're calling it respiratory acidosis. So just by looking at the history of a patient, maybe that's giving you an indication of what you would expect, right, to find in the arterial blood gas. So to be respiratory acidosis, high carbon dioxide, low pH. Right. Then we move on to respiratory alkalosis, hyperventilation issues. Right. They cause a decrease in CO2 because you're breathing so quickly. You're oxygenating okay, but you're blowing off your carbon dioxide levels. Therefore, the level is less than 35 millimeters of mercury. As CO2 decreases, so does the hydrogen ion concentration, and therefore the pH value goes up. pH is increasing and the blood is becoming more alkaline, which leads to respiratory alkalosis. Things that can cause that, anything that can produce hyperventilation, even anxiety, gram-negative sepsis, fever, anemia, right? All those different, sources cause you to ventilate more frequently, above 12 to 20. Remember, normal respiratory rates are 12 to 20. Therefore, when we have respiratory alkalosis, we find the opposite of those two conditions for respiratory acidosis. Carbon dioxide is less than normal, less than 35, the normal range, and pH is higher than normal, greater than 7.45. Okay, metabolic acidosis. The normal range of bicarbonate is 22 to 26 milliequivalents per liter. So remember, when it comes to the metabolics, you can either, and especially with acidosis or alkalosis, we either are, in this case, acidosis, gaining hydrogen ions or losing bicarbonate here in red. So you have to look at what's happening here in that patient. HCO3 is bicarbonate. Bicarbonate is alkaline. Think Tums or baking soda. The pancreas makes a lot of bicarbonate to buffer the acids of the stomach. So bicarbonate is a really good buffer for those hydrogen ions. The kidneys secrete hydrogen ions in urine. If one is not urinating, appropriately, such as in renal failure, they can end up retaining hydrogen ions and become acidotic. If you lose a lot of bicarbonate, as in diarrhea, right? We said prolonged diarrhea, then we can become acidotic, right? So we just mentioned a couple sources of gaining hydrogen ions, or we're losing bicarbonate. We could even, when it comes to diarrhea, we're losing bicarbonate. Ketoacidosis, that is increasing your hydrogen ions. So our salicylates are ingesting too many aspirin because that's salicylic acid. Maybe renal dysfunction. Any one of those, either are causing a gain of hydrogen or a loss of bicarbonate. So to be called metabolic acidosis, the bicarbonate in the body will be less than the lowest range of normal, less than 22, and pH will be less than 7.35. So this is why they're trying, they'll be, when you get into nursing or whatever program, they'll often say, hey, when bicarbonate and the pH are going in the same direction, don't even, I think they're gonna tell you, don't even look at carbon dioxide. And I would disagree with that, but they said you're gonna call it just automatically metabolic acidosis. And if they go in the same direction, when bicarbonate and pH go in the same direction, it's a metabolic, either acidosis or alkalosis. And when you have carbon dioxide and the pH going in opposite directions, then you're going to call it a respiratory acidosis or alkalosis. I would be careful with that. I think it's better to understand, what is happening in the body and how you're getting there, because it really helps put together the etiology of the patient. Like, what are they trying to tell you if they just give you information about the patient's history? And from there, you're supposed to, without having arterial blood gases, to determine, are they metabolic or respiratory, acidosis or alkalosis. This starts to give you like an idea of that. Metabolic alkalosis, you are either losing hydrogen ions or gaining bicarbonate, right? Just the opposite of what we looked at with metabolic acidosis. So prolonged vomiting, losing hydrogen ions. Diuretics, losing hydrogen ions. Antacid, gaining bicarbonates. What if you ingested a bottle of antacids? Then you would be ingesting, more bicarbonate. So the pH, you have a lot more buffer to interact with hydrogen ions. You're increasing your pH because you're decreasing the hydrogen ion concentration. What values would be elevated? Right? The pH, and the bicarbonate levels, and what would you call it? Metabolic alkalosis. Okay, so when it comes to steps to figure out where you are, when you're just looking at arterial blood gases, and example one there is giving you data. They said, okay, the data from your first sample, the pH is 7.31, the CO2 is 52, and the bicarbonate is 24. So I would suggest doing it always the same way all the time. I start with the pH. So I call it, assigning it its last name. Is it going to be acidosis or alkalosis? So you look at the pH value, and that will serve you well when you get into more complicated situations, such as partially compensated and fully compensated states, because now all of them are going to be out of range. Well, the exception of the fully compensated, you'll have a normal pH, but the other two will be out of range. But you still need to start with the pH value that you're currently looking at. Okay, so this is what I do. I look at always pH value. Is the pH normal, high, or low? And I might just put an N over the top of that, or an up arrow or a down arrow. And then I write in there. Let's say if it was higher than normal, then I'm going to write alkalosis. If it's lower than normal, I'm going to write acidosis. And in this case, it's lower than the normal range, 7.31, right? So I write acidosis. Carbon dioxide, 52, high, low, or normal. So if it's normal, I put an N over that carbon dioxide. If it's high, I put an up arrow. If it's low, I put a down arrow. And in this case, it's high, right? Because the normal range is 35 to 45. So I put an up arrow or over the carbon dioxide. And then the bicarbonate, 24. Well, that's normal, right? So I just put an N over the bicarbonate. So I have pH out of range, carbon dioxide out of range, but the bicarbonate's normal. So which phase am I in? I have pH out of range and one of these two out of range. So that means that I am in an uncompensated state. So now I have the first uncompensated. And then I look at the carbon dioxide, or whichever is out of range, and I was like, well, if it's carbon dioxide, it must be respiratory issue because the bicarbonate is just normal. So it's an uncompensated respiratory acidosis. But then I look at it also, and I go, using my head and using what I know about the carbonic acid cycle, does it make sense that if my carbon dioxide levels are higher than normal, it will decrease my pH? And yes, right? Yes, it will. So when I get to the end of this, I'm like, let's confirm. I always check to make sure that there's a correlation between the pH and the animal out of range, and that it makes sense. Would a higher than normal carbon dioxide level produce a pH of 7.31? And the answer is yes. Why? Because for two reasons. We're going to go up because we know the carbonic acid cycle, increase CO2, increase hydrogen ions, decrease pH. We looked at that in the respiratory system, and for people who were in my lab, we looked at in the respiratory lab exercises. But in addition to that, we said here, look, when it comes to a respiratory acidosis, when you have carbon dioxide levels that are higher than normal and pH that's lower than normal, that is the stuff that comes together to be respiratory acidosis. So if you don't want to maybe understand how you got there, just know that, For it to be a respiratory acidosis, carbon dioxide levels have to be higher than normal and pH lower than normal. And if whatever's going on in the bicarbonate, the bicarbonate will actually end up being higher than normal after a while. And then that those two conditions are met to call it respiratory acidosis. If we had lower than normal carbon dioxide levels and higher than normal pH in that, and the bicarbonate was normal, in that sample, then we would call it respiratory alkalosis. Again, we'll just look at something back here real quick. Okay, so we're just going to move on. I saw something I thought might be a typo, but I'm just going to keep moving. All right, so something to keep in mind when it comes to compensated metabolic acidosis. And again, we're really going to talk about this if you come to the acid-base balance. But for those people who want to know, I believe your questions and the quizzes and the exams for this material are going to keep you in the just identifying an uncompensated state where you have pH out of range and bicarbonate or carbon dioxide out of range. But let's say you want to know a little bit more. And when it comes to compensated metabolic acidosis or alkalosis, is that the pH is going to be in a normal range. Once you start really correcting this, and now you have, because that's why we're calling it compensated, metabolic acidosis, because you formerly had a lower than normal pH from one of those metabolic sources, either a gain in hydrogen ions or a loss of bicarbonate ions. But it's at least, adjusting the pH. So you have to look at that pH range or the current pH and determine whether just prior to this, because you're normal, was this acidotic or alkalotic, prior to this. Now, if I tell you it's a compensated metabolic acidosis, then clearly you know that. But if you're just looking at an arterial blood gas, you don't have that information. You just have this snapshot in time. So you're going to look at the same thing. You're going to look at your pH, carbon dioxide, and bicarbonate levels. And I would do the same thing. Look at pH, high, lower, normal. Make a notation above it. Carbon dioxide, high, lower, normal. And then bicarbonate, high, lower, normal. And when you do that, then you go, okay, I've got a pH that's normal, but the other two things are out of range. Those are the conditions for that gray box, some kind of fully compensated something, all right? So that's all because in that box, it says pH is normal and both carbon dioxide and bicarbonate will be abnormal. All right, so let's go to the pH as usual. Start with your pH. If you're looking at a pH that is between 7.35 and 7.3999, 999, then halfway through your, the mid-range of your normal pH range is 7.40. So they're saying anything less than 7.40, but greater than 7.35, so you're at the low end of the normal pH range, then we are going to assume that it was acidotic prior to this, period. If you're looking at a pH value that is 7.40 inclusive or higher, but less than 7.45, because otherwise, we would have an abnormal pH, then it means you had been alkalotic, you had been higher than normal, and you've adjusted it and brought back down. Right? So you use that rule of thumb, 7.40, right in the middle of the pH range. In 7.40 inclusive and higher means you've been alkalotic. If you're less than 7.40, then you had been acidotic. And that is because when you compensate and attempt to adjust the blood pH, you will never cross midline and overcorrect. And that's the premise behind that. Okay, so there is a website. If you put this into slideshow mode and click on the Welcome to Hanson Nursing, it will run you through, it'll give you some, just kind of advance through a few pages. And when you get to the case studies, you will be able to look at that. Matter of fact, I'm going to click on it and let me stop my share and reshare. And let me see if I can just show you a few of those. Oh no, it's not sharing. So let me try again. back down to the end so you can see where to find these. Okay, now it's picked up that page, so let me reshare it. And there it is, finally. All right, so I'm in the nursing website. I'm going to try to advance a few pages. You know, everybody has kind of different ways they're going to explain how you address acid-base balance, but I truly believe, having done this for quite a while, that that is the easiest way. Start with looking, look at high, low, or normal of everything. Use the current pH level to determine whether you're acidotic or alkalotic, determine what phase you're in, and then, whether you're uncompensated, partially compensated, fully compensated, and then name it based on, is it respiratory or metabolic? Do the pH and the carbon dioxide levels, you match up in the ways that I told you. If they're opposite to one another, you're going to call it respiratory. If they're not opposite to one another, then look at the bicarbonate and see if they go in the same direction. Then you're going to call it metabolic. But I think if you look at the etiologies, it's going to help. Here it talks about step 2, looking at your different, what is some of the differences between respiratory and metabolic. And then it will take you again to step 3. In order to recognize compensation, look for a change in the buffer system. You can look through that. I think my method is way easier. And then you start looking at their case studies. All right, so here's case study number 1, and then you can look through these on your own. It gives you some history, but it also gives you in the bottom here your pH, your carbon dioxide, and your bicarbonate levels. So, the PA for carbon dioxide, just think of it as the carbon dioxide concentration. Let's go to partial pressure, but anyway. All right, so it tells you that a client is recovering from surgery, post-anesthesia, is difficult to arouse 2 hours following surgery. The nurse in the PACU has administered morphine sulfate intravenously to the client for complaints of post-surgical pain. The client's respiratory rate is 7 per minute. All right, so this means something, 7 per minute. Well, the normal respiratory rates are 12 to 20, and this person is only 7. So in your head, you go, okay, if I have a lower respiratory rate, my respiratory is decreased, and what's happening to my carbon dioxide level? Is it building up or increasing or decreasing in blood? Well, if you're hypoventilating, we said we increases carbon dioxide levels. We increase carbon dioxide, we increase hydrogen ions, we decrease pH. Boom. That's what they're trying to help you connect to. Right? And the person not only has 7 respirations per minute, but shallow breathing as well. Right? The patient does not respond to any stimuli. The nurse assesses the ABCs and obtains an EEG stop. Right? So it's already giving you a hint of the direction you're going. Right? So it says the pH is 7.15, carbon dioxide 68, and bicarbonate 22. So pH is 7.15, high, low, or normal, it's low. Carbon dioxide 68, high, low, or normal, high, right? Because you're 35 to 45. And then the bicarbonate 22, high, low, or normal, normal. Remember, it's 22 to 26, so this would be normal. You have 2 things out of range. Right? You have a pH of 7.15, which means you're acidotic, as you would expect, because they told you that the respiratory rates were lower. Carbon dioxide goes up, hydrogen ion concentration goes up, pH value goes down. Carbon dioxide level is high. Well, I guess so, because you're only respirating 7 times per minute. So that makes sense. And that makes sense that the carbon dioxide is high, that the pH value will go down. 2 out of 3 things like this are out of range. The pH in 1, pH for sure, and then 1, either carbon dioxide or bicarbonate, which means that I'm uncompensated. So we have some kind of uncompensated respiratory acidosis, right? Carbon dioxide is one that's out of range. And we're going to call it a respiratory acidosis. Right? And therefore it's correct. Right? So you can go through the remainders on your own to look through there. So you can get an idea of how to use. Sometimes they give you, they ask you to just give a basic. Here, we'll go to the next one. you know, whether it's, sometimes they want you to identify whether it's uncompensated or compensated. Sometimes they just said, hey, you know, is it just a respiratory or metabolic acidosis or alkalosis? Sometimes they give you information as a case study. Sometimes they give you the ABG. Sometimes they don't give you the ABG. They just give you, you know, the case study information, you know, but it'll tell you whether you're right or wrong. It's multiple choice, so give that a try. Okay, so let me unshare this. We'll go back to the notes. And I believe that's it. All right. So that's the end of this chapter.